Good evening, everyone, and thank you for joining. My name is Dr. Sonawari from the medical team of USV, and I welcome everyone to this very knowledgeable session of Dr. KK's Med Talks. In today's session, we will talk about one of the very concerning challenge called as pre-diabetes. The diagnosis of prediabetes is vital as it is a very well known risk factor for type 2 diabetes with a greater risk in the presence of combined IFG and IGT. Furthermore, prediabetes associated with disorders also make the prognosis worse. This session discusses about the scenario when prediabetes can actually be a concern and also what could be the possible treatment of prediabetes in high risk individuals. Therefore, to enlighten us on this subject, let me welcome Dr. P.G. Talwalkar, a renowned diabetologist and senior physician from Mumbai. I'll take this opportunity to introduce our respected panelist.
Hello, Sona. Go ahead. I am eager to answer your questions.
Thank you, sir. And before we start, I will just take this opportunity to introduce you, sir. Dr. Pradeep Talwalkar, he is a renowned internal medicine and general physician working at Talwalkar's Diabetes Clinic, Mumbai. Sir is also the professor of diabetology at SL Raheja Hospital for Diabetes and All India Institute of Diabetes in Mumbai. He has been an invited and eminent speaker at various conferences, symposiums, and CMEs. He is a member of the editor board of Indian Journal of Clinical Medicine and Journal of Diabetes Association of India. There are over 100 publications under his authorship, including articles, textbook chapters, abstracts in national and international journals. And Sir has also contributed to the society by being very active on patient education front to spread awareness about diabetes. Thank you for being with us, sir. So now, without further ado, we will jump right into our session. To start with, as we are talking about pre-diabetes, I would like to know from you what is the prevalence of pre-diabetes that you see in your clinic, maybe over the past 5 years.
Okay. The prevalence of pre-diabetes in our country, which reflects statistics in my clinic, is roughly pre-diabetes is as common as diabetes. So you can say for every one person with a diabetes, there is one pre-diabetic waiting to enter into a diabetic range, but not yet diabetic. As you were talking initially, there are two subtypes of pre-diabetes. One is impaired glucose tolerance and one is impaired fasting glucose. And in many countries, including the countries or including the work in which IDF is associated, they only find out how many impaired glucose tolerance patients are. That's why in some statistics, the number of pre-diabetics are lesser as compared to number of diabetics. But if you add the other subtype of pre-diabetes, that is those with impaired fasting glucose, I'll define what is impaired fasting glucose and what is IGT later on in a due course of time. But when you add up both together, number of pre-diabetics are as many as number of diabetics in our country. As per the latest statistics released by the International Diabetes Federation towards the end of 1921, that means just a few months away, few months before, India had about 77 million diabetic patients. Most of them, or about 75% of them, were type 2 diabetic. And India had about 70 million pre-diabetic patients, pre-diabetic persons. We don't call them patients because they are not yet patients, but they are those whose blood sugar is higher than the normal person's and gradually increasing and entering the range of the blood sugar of a diabetic patient. So I can say about 70 million or 7 crore pre-diabetics are there in our country.
Thank you, sir. That is a really large concern that you mentioned, that it is almost as equal to diabetes. I would like to know now next is what are these glycemic parameters that we are talking about in pre-diabetes? Because we all are, I mean, the patients, doctors are all aware of the glycemic parameters in diabetes. How are they different in pre-diabetes? And in the same lines, maybe if you can elaborate more, as you mentioned in your response previously, the IFG and the IGT also.
Okay, Sona, very good questions. First of all, let me clarify pre diabetics are ordinary people. You meet them in the office, you meet them in school, colleges, playgrounds, trains, everywhere. They usually do not have any symptoms, they are not suffering from any disease, but their blood sugar is higher than those whose blood sugar is classified as perfectly normal, but not as high as to call them a diabetic. So it is an intervening zone. People with blood sugar in an intervening zone with normal on one side and diabetic on the other side are known as pre-diabetics. Usually they are called as pre-diabetics because if they do not take any action, gradually every year their blood sugar goes on increasing, and within a short time, particularly in our country, they enter a blood sugar zone which is clearly in a diabetic range. The why There is one more reason why they are classified as different, why they are not normal. You can argue that they should be called normal till they become diabetic. Why this pre-diabetic? Why there is a separate zone for them? Because they are bound to become diabetic if they do not take care, if their weight keeps on increasing, if they still eat extra as compared to what they should eat, if they still eat junk food, they don't do exercise, they are going to become soon diabetic. And even in pre-diabetic status, their chances of getting heart disorders, their chances of getting high blood pressure, their chances of getting obesity are higher. So, in order to warn them that you are not normal, you are going to become diabetic soon, and you are already in a zone where you have extra risk for getting heart disease and extra risk for getting blood pressure, they are labeled as pre-diabetic. So they remember that they have to make extra efforts to reduce their weight, they have to take care of their diet, they have to take care of their exercise. Unless and until you designate them as pre-diabetics, they don't take it seriously. They will think that they are normal. So they are not yet diabetic patients, they are not yet labeled as patients, but they are on the way to become patients, so they should be warned. Now I will come to your question proper. What are the parameters based on blood sugar levels which classifies them as pre-diabetic, separating them for normal on one side and diabetic on other side? Now, let me tell you first what are the blood glucose or blood sugar values of normal persons. Now, let me have one clarification before I embark further. Glucose and sugar, these are the two words used interchangeably during the talks and lectures. The actual 99 or even more than 99% of sugar in the body is glucose. There are many types of sugar, but for all practical purpose, the sugar in the body, the human body, is glucose. The sugar in your kitchen is sucrose. The sugar you use to reduce the to control the low sugar reaction is dextrose, but sugar in body is glucose. And sometimes, since most of the sugar in the body is glucose, we use terms glucose and sugar interchangeably. The correct scientific word is glucose, but we use the word sugar to describe the same. Now, after having this explanation, let me tell you what is the sugar level in a normal person. In a normal person, if you take the fasting blood sugar after 8 hours fast, it should be less than 100, 99 or below. If your fasting blood glucose is less than 90, 99 or below, your fasting blood glucose is normal. If your fasting blood glucose is 126 or above, you are diabetic. But if your fasting blood glucose is neither 99 or below nor 126 or above, but in the range of 100 to 125, you are pre-diabetic by the criteria of fasting blood glucose. The more common pre-diabetic is the impaired glucose tolerance. That means their blood glucose after they eat or after they take 75 grams of oral dextrose and do their blood glucose 2 hours after swallowing 75 grams of glucose powder, dextrose powder, if that is above 140 but less than 200, then this is pre-diabetes, impaired glucose tolerance type of pre-diabetic. If it is less than 140, 139 or below, then they are normal. But if it is more than 200, 200 or more than 200, they are diabetic. So how do you diagnose diabetes? If somebody's fasting glucose is 126 or above, or if somebody's glucose 2 hours after ingesting 75 grams of dextrose is 200 or above, he is diabetic. He doesn't have to have both the things in a diabetic range. One can be in normal range or in a pre-diabetic range, but one of these two things, if it is in a diabetic range, is diabetic. If somebody has a sugar of less than 99 in the fasting state and less than 140 2 hours after ingesting glucose, it 75 grams of sugar, it is normal. In between, suppose the fasting is say 115, he is pre-diabetic. And or if a post glucose ingestion is say 166, he is pre-diabetic. So 166 afterwards but 80 in the fasting stage is still pre-diabetic. 135 after ingestion but 105 fasting is still a pre-diabetic, and both raised in a pre-diabetic range is also a pre-diabetic. So I have told you three subtypes of pre-diabetes: normal fasting but high after glucose ingestion or after sugar ingestion is pre-diabetic. Normal after sugar ingestion but higher fasting, not as high as diabetic, is also a pre-diabetic. And both slightly elevated but not yet in the range of diabetes is also a pre-diabetic. So impaired fasting is a pre-diabetic state. Impaired glucose tolerance is also pre-diabetic stage, and impaired fasting plus impaired glucose tolerance also is a pre-diabetic state. In addition, there is another way of diagnosing pre-diabetes which is used in United States of America but not yet in Europe and not officially yet in our country. This is diagnosis of pre-diabetes by doing glycosylated hemoglobin or HbA1c. All over the world, HbA1c is used to assess the control of a known diabetic and is considered as a gold standard to assess control of a known diabetic. Young person with a known diabetes and HbA1c 6.5 or less is supposed to be in an excellent control. Middle-aged person or little elderly person with a known diabetes but HbA1c around 7 is considered as a very good control. But if you are not a known diabetic, you are not on drug treatment, you are never diabetic, but your HbA1c is say 5.9, you are considered as a pre-diabetic. HbA1c above say 5.7 but less than 6.5, irrespective of whatever the blood sugar he has, whether you do it or you don't do it, is a pre-diabetic in United States of America. In our country, we diagnose it by doing fasting blood glucose and 2 hours after ingestion of 75 grams of blood sugar, and then we decide. So this is how pre-diabetic is a condition whose blood sugar is raised to some extent, not raised enough to label him as a diabetic, but it is definitely not normal, and we have to label him because at that stage he carries extra risk for heart disease, extra risk for high blood pressure, and high blood itself can increase the risk for heart disease later on. So he has to be warned, ki baba, now it's high time. There is a chance to revert back to normalcy, to revert back your blood sugar to normal, and reduce your extra risk to the to the risk equivalent to the risk of a normal person, so that you can have a long life later on. And what is even more important than long life, you can have a good quality of life, because nobody cares for long life unless it is good quality life, particularly towards the later part of life in old age.
Thank you, sir. Thank you for the very clear classification of impaired fasting glucose, impaired glucose tolerance, how different glycemic parameters play a role in determining which type of pre-diabetic you are. And as you very rightly said in the beginning of this response was, many people, they do not understand that they, or they do not maybe accept that they are pre-diabetes, and they will go on to lead a normal life without acknowledging the fact that they might get progressed to diabetes. So, what my question is, how do you identify these people, or ask them to screen themselves, or as in, if a person like me, if I am pre-diabetes, what are the symptoms I might get, or how would I know that I'm pre-diabetes, if that is the case? And second, what are the risk factors that a physician can check when he is checking for pre-diabetes, or to counsel the patient for a pre-diabetic test screening?
So now, as I told you, most of the pre-diabetics will not have any symptoms. But the most important message I'm trying to deliver is, do not wait for symptoms. It would be late if you wait for symptoms. What one has to do, everybody in this society, what he has to do is as follows. When he crosses 30, whether he is feeling very healthy or not, whether he is an athlete or an ordinary of an ordinary physical status, whether it is he is very strong or not, he should do is fasting blood glucose and 2 hours after sugar challenge blood glucose. That's the only way to pick up pre-diabetes. Otherwise, he will miss. If you wait for symptoms, you would pass through pre-diabetic stage without any symptoms and would straight away land in a diabetic state. Remember one thing, even a diabetic person can remain silent undetected for up to 5 years after the diagnosis of diabetes. Add 5 more years of pre-diabetes. So this particular gentleman, if he just waits for the symptoms, he will be 10 years too late before he starts the treatment or management, and that's why he will have more complications. He will have higher blood sugars, he will have tissue damage, he will have lesser maybe lesser longevity and a bad quality of life later on if he just waits for the symptoms of diabetes. Nobody should wait for symptoms of diabetes. Everybody should do their blood glucose the day they cross 30. If it is perfectly normal, that means fasting blood glucose less 99 or less, post glucose challenge blood sugar 139 or less. He should repeat it after 2 years, even though even after 2 years he is in perfect health. If he has found to be diabetic during that stage, and don't be surprised if you some of them will have diabetes at that stage because they should have done the blood sugar earlier, then you will ask me, then why you are not reducing the limit to 20 years? Yes, if somebody is overweight, if somebody already has high blood pressure, if somebody has a strong family history of diabetes, and if a person is a lady and she's only 20-year-old but she had a difficult labor, the child born was having a higher weight, chubby child, they had to do cesarean section because otherwise it was impossible to deliver the child. This particular lady should not even wait for 30. She should do blood glucose immediately after the delivery. And those who have a strong family history of heart disease, strong family history of very high cholesterol, high blood pressure, those who are obese should start doing this blood sugar not after 30 but after 20. Now, what happens if it is perfectly normal? Do it every 2 years throughout your life. If it is diabetic, start the treatment in diabetes range. As I told you, don't be surprised if small number of them are already diabetic at that stage. And if it is in between, if it classifies the criteria of pre-diabetes, if it is in a pre-diabetes range as per the criteria which I defined very clearly, Then you immediately start lifestyle modification. What do you mean by lifestyle modification? Lifestyle modification means appropriate diet, appropriate calories as per your physical activity, and cutting off of excessive oily food, excessive food with red meat, fatty food, excessive salt, and do a prudent dieting. Reduce your extra weight by proper exercise, at least 30 minutes walk every day, at least 5 times a week. That means at least 150 minutes walk. Walk for physical exercise, not the usual walk going to the bus stop in a leisurely manner, in your office, walking from here to there. Continue that. In addition, 150 minutes of a brisk walk. Start implementing that. Do your blood sugars every 3 months, 4 months to see that you are not advancing into diabetes. Try extra efforts to ensure that you are not only advancing to diabetes, but you are reversing back to normalcy. Lot of people can reverse back to normalcy if they do a prudent diet and if they start taking exercise. So, depending upon your blood glucose, you repeat your sugar every 2 years. If you're perfectly normal, start diabetes treatment and do as per diabetologist. That means initially every 15 days, once or twice, and then once you settle down every 3 months. And if you are in a pre-diabetic range, every 3 to 6 months, you have to repeat it. This is how you start monitoring yourself. Of course, you will every time, every 3 months at least, you will also record. If you are a pre-diabetic, you will record your blood pressure. You should take your ECGs. You should take care of your heart. If you have symptoms like getting tired early, breathlessness, or chest discomfort, you should take ECG. If he says, if a doctor still has some doubt, he will ask you for 2D echo. If he still has certain doubt, then he will go in for treadmill. He will ask you to do treadmill stress tests, etc. But these tests, particularly treadmill stress tests, 2D echo, are required in a very, very minuscule number of patients at that stage of life where a person is very young. But depending upon your symptoms, depending upon your signs, depending upon your blood sugar levels, the blood pressure levels, the cholesterol levels, a doctor will take an appropriate action. So see the doctor who is well qualified and then have a belief in him.
Thank you, sir. Thank you so much. So, dear audience, till now, sir has explained us about the prevalence of pre-diabetes, how important it is to screen pre-diabetes, how are pre-diabetes glycemic parameters different from diabetes glycemic parameters, and the mainstay of pre-diabetes management is lifestyle modification, as sir very rightly and very clearly mentioned: exercise 150 minutes per week, diet to include more of fibers and vegetables, and to cut down on oils, sugars, fatty acids, fatty foods. So all these things coming together as lifestyle modifications in the management of pre-diabetes. So sir, moving ahead now, the next part of this, I mean, now it is often noticed that implementing lifestyle intervention has been a challenge across the globe. Poor long-term compliance. I mean, people are not yet ready to go for exercise or go on diet. And by diet, we are not even meaning the strict diet. People are still going to go and eat. So, in such cases, how do you recommend about a pharmacological intervention, or how do you approach this situation? Non adherence
Yeah.
of lifestyle management.
So once a person has been diagnosed to have pre-diabetes, a duty of a doctor is to halt the progress towards diabetes. That's step number one. And step number two is try to reverse the process and reduce the blood glucose to levels which are classified in a normal range. How to do it? Everybody should start with diet and exercise. We talked about what kind of exercise. Minimum is 150 minutes of a brisk walk every week and something equivalent of that. That means somebody can jog, somebody can cycle, somebody can use stationary cycle. So he should not have a bahana that in Mumbai it rains too much. This year it was too much raining. How can I go out? That's why I didn't go out and my blood sugar was raised. You keep a stationary cycle at home, or go to the gym and have a treadmill, or go for a swim, or take a, play a game of tennis or badminton. So this is as far as exercise is concerned. We talked about diet, prudent diet, avoid junk food, avoid excess of fatty food, oily food, excess of salt, excess of red meat, avoid simple sugars, that means avoid sweets, avoid jaggery, avoid sugar, of course, and reduce the number of calories if you are overweight. Some people, in spite of doing all this, cannot prevent the onward progression of blood sugar towards a diabetic range. Some people may have a backache. Some people may have a knee joint problem because of which physical exercise is limited to them. Some people may have some other problems, say asthma or bronchitis, because of which they cannot do exercise. So this particular mode of treatment is not available to them. So they start with a little bit handicap. In these patients, you can employ the pharmacological treatment to reduce blood glucose and to prevent progression to diabetes and to encourage regression to normalcy. There are certain drugs which can be used in this situation. Now, what are these drugs? The number one drug tested all over the world, including developed countries, developing countries, countries across the continent, is metformin. Now, the first trial with metformin was done in the early part of this century, first few years of this century in United States of America. And this was a massive research work, and this is known as diabetes prevention program. They took thousands of patients in a pre-diabetic range, gave diet and exercise to all of them, and in addition gave metformin to some of them who were not able to do the diet for purpose of studying and doing research. They found out that even metformin could reduce the onset conversion of pre-diabetes into diabetes by 38% as compared to those who did not take metformin or did not do any diet or exercise. That means the reduction in the risk for developing diabetes was cut by 38% in those who took metformin. It was cut by 58% those who did diet and exercise, but still some of them cannot do diet and exercise. I have given you many reasons where diet and exercise is not possible. In such situations, metformin is world's number one drug to reduce the chances of conversion, the risk of developing diabetes in this. 33% relative risk reduction in metformin. The second drug is known as acarbose. It's a different kind of drug, but the relative risk reduction was only 25% as compared to metformin. Now, acarbose, there is only one big trial all over the world, but with metformin, there are several trials, including a major trial done in Chennai in our country, again in a large number of patients, and again following more or less same design, which was followed in United States of America in a research work which is very famous under the title Diabetes Prevention Program. In our country, the results with metformin were even better as compared to results with metformin in United States of America. I told you metformin worked very well, but diet and exercise worked wonders. In our country, the results with metformin were as good as results with diet and exercise. So, what we do in our day to day practice is that we don't tell the patient immediately that you have a metformin, you don't have to diet, you don't have to exercise. That would be very wrong from our side, and that would send wrong messages to the patient. We harp on benefits of diet, benefits of exercise, insist and encourage them to follow diet and exercise. But after a couple of times review, if we find that this fellow is not going anywhere near our goal set by us to him, we find out the reasons, and if there are reasons which are interfering with diet and exercise, then we start metformin. And we start metformin also in those people who have a very high pre-diabetes blood sugar level. I'll explain you what do I mean by a very high degree of pre-diabetes. What do I mean by high degree of pre-diabetes? Say 141 is also a pre-diabetic and 199 is also a pre-diabetic. Now, common sense tells you that if you are 199 on a particular day, you can be 198 on next day, 202 on third day. On the same day at the same time, if you divide your blood drawn from your veins into three different labs, one will say 198, another will say 202, the third will say 203. So when you are sure that this fellow is technically pre-diabetic, but for all practical purposes diabetic, and it's now too late only to depend on diet and exercise, we can start metformin along with diet and exercise right from the day one in. So high degree of pre-diabetes is one indication in which we can use the drugs such as metformin, because it's number one drug for prevention of diabetes in a pre-diabetic, right from the day one along with diet and exercise. But in others, we will try our best to encourage the patient to follow diet and exercise. And at a particular stage, when we know that he is not going anywhere, we take a pragmatic decision of adding a drug. And for all practical purposes, the drug is metformin. As I said, other drug is acarbose, but the results are 25%. The third drug is pioglitazone, but results were extremely good, but at the cost of massive increase in weight, which nobody wants, because in a long term, there are a lot of disadvantages of gaining weight. So that's why, even though there is an excellent paper, excellent research work on role of pioglitazone in prevention of diabetes in those with a pre-diabetic, it is not used in a day-to-day practice. There are certain other drugs, but some of them are injectable, some of them are very costly, some of them are with side effects. So, for all practical purposes, the only drug which is used in a day-to-day practice for prevention of diabetic in a person with pre-diabetes is metformin. And what are the indications? High levels of pre-diabetes. What is the second indication? Somebody may be in a mid pre-diabetic blood glucose level, but he has a pre-diabetics by fasting. Impaired fasting glucose also is pre-diabetic, and impaired glucose tolerance criteria also is pre-diabetic. So when you have two different criteria to satisfy the diagnosis of pre-diabetic, the by practice or by experience, it tells us that this fellow is going to be diabetic soon. So this is another indication for us to start metformin. The third indication, of course, is those who are unable to do exercise or unable to follow dietary advice. You have tried your best, the person has tried his best, but his blood sugar is still advancing slowly but surely towards the diabetic rate. That is another patient in which we start metformin earlier as compared to others.
Right, sir. Thank you. Thank you for marking a clear distinction between when to use metformin, or after how many follow-ups of the lifestyle non-adherence should we start metformin. And it is also very important to identify those high-risk individuals with pre-diabetes who will have that capacity to progress into diabetes faster. And after identification, so it is always better to start with a pharmacological agent in these high risk pre-diabetes individuals to prevent the progression. So, sir, you also mentioned about the trials that showed the evidence of safety and benefits of metformin in pre-diabetes. Can you elaborate to our audience about the guideline recommendations, if any, for metformin, the diabetes guidelines?
I would refer you, most of the guidelines say the same thing: start with diet and exercise. And if you are unable to give him benefits of diet and exercise, start with the drugs, the main drug being metformin. The guidelines also say that side by side, while you are tackling the blood sugar, You must tackle the waistline or weight. You must tackle the high blood pressure if it is there, or take preventive steps to prevent increase in blood pressure by cutting down on salt and weight. And you also tackle hyper high cholesterol levels. So don't have a tubular vision of concentrating on only blood sugar. Simultaneous attack on blood pressure if present, high cholesterol if present, expanding waistline or general increase in weight if present will work wonders. Another thing is that I will also point out the guidelines issued by the American Association of Clinical Endocrinologists and jointly with American College of Endocrinologists. What they say, and of course, they have said if a patient has diabetes by pre-diabetes by more than one criteria, I talked about American situations in which they also use HbA1c to diagnose pre-diabetes. So they have three criteria for diagnosis of pre-diabetes, and anybody who satisfies the diagnosis of pre-diabetes by more than one criteria, American College of Endocrinologists is advising the use of drugs, and whenever a drug is recommended, the drug of first choice is metformin in this particular indication. The second guidelines, what they are saying, and those who are very high risk patient, that means those who already have a high blood pressure, those who are already have high cholesterol, those who are high, those who have a high waistline, these are the patients who are going to get converted into diabetes faster, and these are the persons who are going to have complications of pre-diabetes like myocardial infarction or hypertension earlier. So these patients also should be treated with pharmacological treatment such as metformin in addition to diet and exercise.
Right, sir. Thank you. Thank you for that very clear insights. So it is also known that the progression of pre-diabetes to diabetes and associated complications can also increase total health expenditure in the long run, like just how you mentioned about myocardial infarction or hospitalization due to CV events. So, in your opinion, would metformin be more cost effective than lifestyle modifications in such people to prevent or delay the onset of type 2 diabetes?
Yes, to some extent, metformin would be cost effective. Somebody should take up this issue in the pharmacoeconomic study on metformin. But of course, the cost of treatment of complication of high blood sugar is far, 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 far higher than cost of management of high blood sugar. And metformin is the most inexpensive anti-diabetic drug available anywhere in the world. Is just less than the ordinary metformin will be just 1 rupee or around for a tablet, and many of the costly medicine will cost you 50 rupees a tablet. So metformin is a wonder drug. It's available. It was launched in Europe in the year 1957. It was launched in India in the year 1963. Many of the anti-diabetic drugs which came soon after metformin retired long back. What do I mean by retired? Gradually their side effects were known, and the people started banning them. The various government authorities started banning them, or before they were banned, the companies withdrew them. There were so couple of sulfonylureas which retired long back, another bivonide which retired long back. Metformin is the oldest oral anti-diabetic drug, which is available continuously in Europe since the year 1957, continuously in India since the year 1963. India, which is known as a pharmacy of the world, is manufacturing 80% of the metformin for the consumption all over the world, and it is the least expensive. It is a drug which has a very good effect on diabetic patients. It has a very good effect on pre-diabetic patients. And as I said, coming back to what where I started, the cost of managing complications of diabetes such as high blood pressure or heart attack or stroke is several times the cost of managing diabetes, particularly with simple drugs like metformin. So it is definitely cost effective.
Thank you, sir. Thank you so much for this. Your response about the confidence or the confidence that a person should have on this drug metformin because it is safe, it is effective, as you said, the oldest drug that is there for diabetes, and taking all, as you very rightly said, the wonder drug, and taking all the benefits. The cost also is very feasible for everybody to take up this pharmacological agent, especially in case of high risk pre-diabetes or diabetes.
So now I
We
want
have
to make
some
one
questions.
point very clear here before we move further, if we have a time. Old age doesn't mean less effective. Most of the old drugs are not used very commonly in a day-to-day practice. They are just kept as reserve. Somebody who can't afford, then you
Hmm.
take it. Somebody who can't tolerate, then you take it. But metformin, in spite of being the oldest drug, is also the most commonly used drug, most strongly recommended drug across the globe in all the guidelines issued by all the diabetes associations, including the World Diabetes Association in year 2022, give primacy of treatment to metformin. So, in spite of being old, it is still the most effective, most widely used drug in the management of diabetes.
Very rightly said. Very rightly said, sir. Thank you. So, if you don't mind, we have some questions from the audience. First question is, sir, if a person is lean and pre-diabetic, would it still be recommended to go ahead with the pharmacological agent such as metformin? Lean and pre-diabetic.
See, if he is lean and if he is pre-diabetic, what is important is you are targeting his blood glucose level. If it is coming down, well and good, he doesn't require metformin. You would not start metformin right from the beginning in him. Definitely, definitely, patient's well-being is at your heart. But in spite of being lean, in spite of taking exercise, if his progress of blood glucose towards diabetes is not arrested, then you can give metformin in lean person. Definitely. Metformin is not a contraindication for a lean person, whether he is diabetic or pre-diabetic. You go by the criteria of your ability to halt the progression of blood sugar towards diabetic range. If it is possible without metformin, good, go ahead with that. Otherwise, you can use metformin in a lean person if required, if he satisfies all the other criteria for use of metformin in a pre-diabetic range. Just because if he is a pre-diabetes, he should not become a contraindication to use of metformin. And metformin doesn't make a person lose weight. Metformin stabilizes the weight. Maybe half kilo here and there he may lose.
Right, sir. Okay, sir. Thank you. Thank you for the response. We have one more question. How soon should we start with pharmacological agent after diagnosis of pre-diabetes?
I think I have already answered this question, but I
Hmm.
will repeat the answer so that it goes strongly in the head of everybody. If somebody is almost a diabetic, for all practical purposes, diabetic, you start from the day one of diagnosis of pre-diabetes. If somebody has multiple risk factors, is overweight, he has high blood pressure, he has high cholesterol level, you start very early along with diet and exercise. Never give a shortcut or bypass to diet and exercise. It has to be done along with diet and exercise. If somebody has more than one criteria for diagnosis of pre-diabetes, that means in our country, high fasting glucose as well as high post glucose challenge glucose, you start metformin along with diet and exercise. So it depends on different people. If somebody is 35, his fasting blood glucose is 105 and his post glucose challenge blood sugar is 45, I will never think of metformin at that stage. I am here to help the patient. I am not here to help the sale of metformin. But in many conditions, I will still start metformin.
Right, sir. Right, sir. One more question. So we have received a lot of questions, but as you said, all the questions you have covered because the questions were just coming and you were giving the insights on the same question. So I have selected some questions for you. One more question is pre-diabetes associated with hypertension?
Yes, of course. in a study done under the title Stop NIDDM. Now,
Hmm.
NIDDM was the name used to describe the most common type of diabetes in 90s and about 20 years back. So
Hmm.
stop, we can say stop diabetes. In a study entitled Stop Diabetes, they found out that if a pre-diabetic is not treated with diet, exercise and medications, he has much higher chances of getting high blood pressure as compared to pre-diabetic who is treated with the drug and diet and exercise. And there are a lot of studies which say that the chances of having high blood pressure are higher in a population with pre-diabetes as compared to a population whose blood glucose is normal, but they resemble pre-diabetic in all other criteria, demographic criteria. That means same age, same sex, same socio-economic status, everything else same. You have a pre-diabetic, you have a higher chances of high blood pressure. If your blood sugar is normal, you have less chances of high blood pressure. And if you start the treatment for pre-diabetic and compare your chances of getting blood pressure in future as compared to those who are pre-diabetic but not doing anything to convert their pre-diabetic, as compared to this group as compared to other group will have a higher chance of high blood pressure. So pre-diabetics have higher chance of high blood pressure as compared to normal. If you divide pre-diabetics in two groups, those who have started treatment for pre-diabetes and those who do not take any treatment for pre-diabetes, those who do not take any treatment for pre-diabetic have a higher chance of high blood pressure as compared to pre-diabetics who are under treatment for pre-diabetes.
Right, sir. Right, sir. Thank you. Thank you so much. We have covered most of the questions, and the questions that were that I thought would require some emphasis. I have asked that also. So thank you so much. Any last message to the audience? The conclusion part.
Yeah. So now I will just bring forward one fact and then I will give a very brief last message. The one fact which I wanted very eagerly to bring forward is the rate of conversion of pre-diabetic into diabetes. That means if you take 100 pre-diabetic people every year, how many of them enter diabetes range? The Western studies, there are different Western studies done at different places at different times. Their figures are between 5 to 10%, which means that 5% to 10% of pre diabetic people become diabetic every year. Now, what are Indian studies saying? Unfortunately, we don't have many Indian studies, but a very major study done by Dr. A. Ramachandran from Chennai. Dr. A. Ramchandran has demonstrated that 18% of Indian pre-diabetics become diabetics every year. I know in a 1 year there was a statistics which said that the number of diabetics in India are very high, but number of pre-diabetics in India reduced that year. Now some people who do not have that much knowledge of diabetes were very, very happy. Why they were very happy? They think that today if a pre-diabetic is reduced, tomorrow diabetes will be reduced. But why pre-diabetics were reducing? Because more number of them were getting into a diabetic range. So that's a very bad thing. So in our country, the rate of conversion of pre-diabetes into diabetes is much faster as compared to West. And this is because of our genetic predisposition. We are born with a weak beta cells in pancreas. Our beta cell deficiency is much more higher and much starts much earlier as compared to Western people. Our diabetes starts earlier. We also have a significant insulin resistance. These are the various reasons working together in a joint manner make us more prone to develop diabetes faster as compared to the Western people. So this is the fact which I wanted to bring in front of everybody. And the message is pre-diabetes is a stepping stone towards diabetes. Diabetes is an unwanted condition. It is associated with many complications, shortening the lifespan not in every diabetic but in those diabetic who just don't take any care and have a very high blood sugar, and also deteriorating the quality of life. Some of the complications of diabetes, such as high chances of getting blood pressure and heart attacks, are seen even in pre diabetic stage. In other words, the clock for getting this complication starts ticking in pre-diabetes rather than diabetes. And that's why pre-diabetes is unwanted, unwelcome stage in the life of a person moving from normal blood sugar to diabetes, and everybody should try his best to prevent it. But in order to take the steps to prevent the progression of pre-diabetes or progression into pre-diabetes, one since this condition is totally symptomatic, one has one should not wait for the symptoms to develop, and one should not be complacent saying that I don't have any symptom, that's why my blood sugar must be normal, I am not going to waste my time going to a pathologist. I will see later on when I have symptoms. It's a wrong thing. Everybody once they crosses 30 should do blood sugar, and if it is plump normal should repeat every 2 years throughout the life. He has a high risk that he should start these things at the age of 20, and if he is in a pre-diabetic range he should examine his blood sugar more frequently side by side, implementing the management of pre-diabetes to ensure that his blood sugar is not progressing towards diabetes. In fact, he should ensure that his blood sugar is regressing towards normal. In this way, he will lead a happy life later on in his middle age and old age. He will not only have a long life, but he will also have a good quality of life. In other words, he will add years to the life and life to years. Years to the life and life to years. If you want to add later on in your life, you have to start at the age of 30 and implement whatever I told you. Thank you very much.
Thank you. Thank you so much. Thank you so much for this very comprehensive session to share your clinical pearls with us. Thank you for your wisdom, your clinical experience as well. So it is, I think, for the audience, it is perhaps high time that pre-diabetes is treated with some with the due seriousness. Lifestyle modification is the first line intervention and should be aggressively implemented in individuals with pre-diabetes. And also, awareness should be spread regarding the use of metformin in pre-diabetes for T2DM prevention, especially in high-risk groups with multiple risk factors. Metformin is a generic drug, cheap and widely available. Therefore, the additional use of metformin may be encouraged in subset of these pre-diabetes people with multiple risk factors, which are associated with the highest risk of progression to T2DM. So, thank you, sir, and I hope the clinical pearls that were given by Dr. Pradeep Talwalkar is taken ahead and used in our daily clinical practice to make India the diabetes care capital of the world. So thank you so much for logging in, dear audience. Thank you for all your questions, and till we meet next time. Thank you.
Thank you, Sona.
Thank you, sir.